most of the time, they decide to take the patient back home. And we can understand one thing, that in a poor family, what can these poor people can give what kind of treatment in their homes? It is not possible, sir. It is not possible to give the treatment that is required to the patient at their home. They cannot do anything. The only comfort is that to the attendants, they will feel free when they reach home. They are free from that hospital atmosphere for which they don't like. So when they go home, they are more relaxed and more happy. But I'm talking here about the patient. The patient, when he has taken back home, he will face all pain and agony. And who can take care of such kind of patients at this poor home, at their poor family, sir? So why I'm so concerned for this subject, even though I said at the opening remarks that I may not be the best person to speak on this subject, but because I have the opportunity in the family to always talk about health matters, about health subject, because I'm fortunate to have my daughter who is a doctor, and I have my wife who is a nurse, and myself also, I'm privileged to be a student of MBA in hospital and healthcare management, for which I'm still studying, sir. So that's why I have the patience to spend time to think, and I have written also in my assignment on this matter. Sir, it makes me more concerned when I know some families are facing such kind of problems in the rural areas. I will not name the village. I will not name also that particular patients. But I know there was an instance that one patient committed suicide himself because of the non-availability of such kind treatment at home. One patient, after taking 4 or 5 hospitals, from one hospital to another, and their families, they are poor family, they find so difficult to spend. Whenever they take the patient to hospital, they keep a long list of prescription of medicines, and they have to buy those medicines. But this poor family can no longer afford to provide those medicines that are required for that particular patient. And at the end of the day, they also understand from one hospital after another that the hope to cure this patient, it's not there anymore. So ultimately what they do, they understand this and they take that patient back home, waiting for the time to die. But that patient, he didn't die for so many days, so many months. The family member, sorry to use this word, they thought that they will take home, and they know also that he is going to die after a few days. But he didn't die. So ultimately, this patient, he has to face the pain and agony every day. And he don't dare also to tell the children to go to hospital again, because he know the condition of that family. It is a very low income group family. And he knows also the fact that he had spent during the treatment all the resources that he have. It has been spent already. So he has to face this pain and agony at home, sir. He has to face that pain and agony at home every day. And what happened? On one fine day, when he see that there is an opportunity, when all his children is not at home, he take that sad decision to hang himself, and he died. This incident sorry, sir, I'm emotional on this. I'm emotional on this matter. This incident has touched my heart, and I thought the government can do something to prevent such incidents. The government can do something to prevent such incidents because we have so many poor people, so many poor patients in the state of Meghalaya who cannot afford this costly medicine, who cannot afford the required medicines which are required, especially those life-saving drugs which are very, very costly. We understand how many poor family can afford. That's why, sir, I bring this motion for discussion in this house today. That as a government, I do not know, Honorable Minister in charge Health and Family Welfare, she is the best person to know what kind of treatment do we give to such kind of patients who are struggling and whom we know also that it's difficult to cure. What kind of treatment as a state government we are giving as of now? But to my knowledge, sir, most of the poor patients, they came back home when they know that they are not able to cure anymore. Sir, I want to draw the attention of the government through this motion that it's very, very important to create such facilities. And if the government can give the direction to the doctors to classify and the senior doctor to determine, to declare which patient, who is the patient who required this comfort care treatment. If it's not there in the subject of the health department, I felt it is very, very important to have that classification, that patients who reach at that stage due to chronic diseases should be given that classification as comfort care treatment.
Sir, as correctly indicated by the mover of this motion, comfort care treatment is designed to alleviate symptoms, manage pain, and enhance the quality of life for patients facing serious illnesses, chronic conditions, or those nearing the end of life. So disease is very cruel, sir. There is no bar, no age bar. There is no social strata bar to patients who have endured this big challenge of illness. What is most painful, sir, is in this generation, newborns are also not out of the challenge of this very important attention drawn by the honorable member in his emotive motion, sir. Today, sir, rarely you will find any member of the community who has not felt the pain that the honorable member feels. And yes, sir, I empathize with him and the thousands of families who do not have this privilege of coming to a Meghalaya Legislative Assembly to discuss their problems. This is the dynamic nature of the Department of Health and Family Welfare, sir. We are very aware, sir, that palliative care is an expensive affair. But Government of India, Government of Meghalaya is now well seized of this challenge. We are approaching to better diagnostic centers, comprehensive infrastructures to attend to all of these various diseases that cripple the community to the extent of a feeling of helplessness. I too have felt it. And I too have seen in my tenure of an MLA, the extent of damage that disease can cause to families and communities. So I have two options before me. One, just read this prepared speech. Or two, concentrate on the areas of concern and go out of the predictable nature of a minister reading out a speech. And I choose the latter, sir. I will try my best to enlighten this august house. Very often, the cart before the horse parody is an often taken route. Condemn. Look at the weaknesses. Look at the shortfalls, the shortcomings. But sir, in this day and age, sir, the Department of Health is rising to the challenge. Sir, in response to the Honourable Mover of this motion's point about the technicalities of LAMA, leave against medical advisory. So very often, a doctor in our facility, though his heart is with the concern for a patient, needs to leave decision taken to families and family parties. We have seen, Honorable Deputy Speaker, sir, that patients had a good chance to be treated by our doctors, but preferred to leave against medical advice. Once the patient is taken out of the care of the hospital or the facility concerned, there is degeneration. There are so many factors which lead to patient parties opting for LAMA. And by the time they bring back a cancer patient to our facility in civil hospital or Tura hospital, so many experimentations have been experimented by patient parties. And usually they come at the very last, most painful stage. But yes, should a government facility prepare itself for the eventuality of this deterioration of a patient? Yes. We are strengthening our facilities through the Pradhan Mantri Jan Arogya Yojana, the PMJAY scheme. And sir, we are strengthening our secondary and tertiary care hospitalization for such vulnerable populations. What are we doing in this scheme in the government of Meghalaya with its state component of share? And the consolidated effort put in by the Department of Health and Family Welfare. Sir, we are financing and investing valuable funds to upgrade our various health facilities. The Health and Wellness Center, sir, is a scheme that circles around predominantly over and above the immediate medical attention that a patient may require, even if it's not a life-threatening situation. But it hovers around care. We are looking at a care which is curative in nature, which is rehabilitative in nature, and we are definitely including the palliative care in the packages that we offer for the universal coverage of healthcare for every citizen of the state of Meghalaya. So the Department of Health and Family Welfare and its huge battery of doctors, specialists, medical officers are of the opinion that we must change gear in our approach to tackling the problems of healthcare in the state of Meghalaya, to attend to the changing dynamics of presentation of various diseases in the state of Meghalaya. We are investing heavily in the non-communicable disease program of the state of Meghalaya. Very often, sir, members may have experienced personally or in their service as MLAs, suddenly out of the blue you hear that the patient you just met in the morning collapsed and died. So therefore, preventive care has to take presence in all of our activities in our various centers. So we have also looked at improving the kind of facilities that we have in our institution and reach one step further towards the person, service to the person who's suffering the most. So we have the JAS, which is very much in operation in the state of Meghalaya. This is the Jan Arogya Samitis. Who is constituting the JAS team? Every DC in every district has been told to initiate a JAS presence in every village. You have the community, you have a convergence of our ASHA workers, we have the Anganwadi workers, and we have the village health council authorities. So this team, sir, is a team which looks at treatment away from hospital. We have home visits, we have door-to-door checking and collection of data and survey of patients, so that we are able to, as a government, expand our MHIS scheme, so that it becomes a dynamic list which is conditioned primarily not by predictable diseases that can be attended to in the universal coverage, but particularly to ensure that whenever the need arises, the MHIS should and must coverage any disease and requirement thereof by a citizen of the state of Meghalaya. So we also have worked on the e-Sanjeevani networking, what we call digital health integration, so that a patient who is in need of medical advice and attention, even if being treated at home, can access through these teleconsultations that are there. But maybe awareness is the need of the hour. We have to publicize the presence of these institutions that are there at every village level. Today, in the e-Sanjeevani networking digital health integrated system, we have 51 specialists which have onboarded themselves. But maybe people don't know. So palliative care, like I said, has no age bar, has no community bias. It is across the board. And the state, in its ambitious intention to start the 2 medical colleges which are run by the state government, will also achieve the same end. We have been finding problems finding specialists. So what is most painful is that Alzheimer's, dementia, and other such diseases are slowly consuming our population. And sometimes the way out is to educate the masses. We have to educate the masses to move away from practices which have been practiced for long. I have a cancer, the doctor can't treat me, let me go to a natural healer. Does that work? We need to fight this. A systemic corruption within ourselves, which is detrimental in the long run to the population at large. We need these specialists, and these 2 medical colleges will create the gap that is there, and that is why we are determined. And I must also thank the Honorable Chief Minister for his constant support to the Department of Health and Family Welfare. Time to time, we go to the Honorable Chief Minister to discuss the dynamic manifestation of some of the diseases that are slowly becoming important. I am confident that 5 years down the line, we will have trained personnel. Today, neuro-onco-surgeons are rare in the state of Meghalaya. Hence, patients have no option but to leave the comfort zone of their homes and get treatment in another location, another state, sometimes even overseas for those that can afford it. The government of Meghalaya, through the Department of Health and Family Welfare, is well versed with a comprehensive geriatric care. It's a consolidated policy. Yes, it is always, we are always ambitious of expanding our facilities. I will not commit here, but I will assure the Honourable Member that in the existing centres, we are already designating a 10-bedded geriatric ward, Civil Hospital, Shillong and Tura, Jowai. We are on the job, sir, and we hope to be able to achieve it, sir.
Thank you.